Hi friends, I'm Dr. Meghna Krishnan and I'd like to share with you about a case of cryoablation that we did where a multicentric 9 centimeter ulcerated invasive lobular carcinoma could be treated. So I'm a breast and body radiologist, an office there, and this is our practice name and phone number, and we provide automated 3D breast ultrasound with AI, 2D breast and body ultrasound with color Doppler and elastography, ultrasound guided aspirations and biopsies, second opinion reading, breast cancer cryoablation, and REMS echo light ultrasound, which is ultrasound for bone density and bone quality for knowing osteoporosis, osteopenia, and also the fragility score and 5-year fracture risk. So here's the patient for the breast cancer cryoablation. She is a 67-year-old female. In 2022, she had a locally advanced large ulcerated left central breast mass with axillary metastasis. It was ER positive, that is estrogen positive, progesterone negative, and HER2 neu negative. And I'm sorry for these graphic photos, but this is how it was in 2022, where you can see how locally advanced it was with involvement of the skin. So she underwent holistic oncological management with insulin potentiation therapy, low-dose chemo, a whole range of different treatment options that her naturopathic oncologist preferred, and she declined surgical and radiation management at that time. It was in 2022, and in just a matter of 1 year or so, she really improved, as you can see, even with that holistic treatment. In 2023, she had an area show up on the left side, and the ultrasound showed that there was now a mass at 11 o'clock, 3 centimeter from the nipple, which had blood flow, and there was a second mass at 12 o'clock, smaller one, and then a 4 o'clock mass. So 3 masses were brought to our attention, saying that, this may need help. Now, her reason for cryoablation, basically mastectomy would be the option in surgical world, but she was really interested in cryoablation. She wanted us to treat the lesions, and she had heard about the abscopal effect, which is an immunological benefit that one could get through cryoablation, where the dead tumor DNA is available for the immune system to recognize and mount a response and maybe treat itself. That has been shown in the mice and anecdotally in cases around the world, and also we know it from radiation experience too, that this is possible. And cryo, you don't need general anesthesia, so that's an advantage. And the most important, I think, subjectively emotionally to every woman, is that she gets to keep her own native breast. Though there are excellent reconstruction options these days, I think women prefer to have their own breast if they could. So as we already know, when she came for the cryoablation, we saw this and we said, hey, this is extensive. It's not just 3 isolated masses, but this is a large area of the breast. And we did the ultrasound, and we can see this hypoechoic mass at 11 o'clock, and you can see that it's touching the skin. There's no gap between the skin and the mass itself. Typically for cryoablations, we put a spinal needle and give saline to separate the skin from the mass so that we can prevent frostbite to the skin. But in this case, it wouldn't be possible. And she has implants too, but implants are okay in cryoablation. The ice ball doesn't really damage the implant in any way that we've seen. So that was not a big issue, but it's nice if you can separate the mass from the skin, or the implant if you could, but in this case we could not. And looking at the extent of the lesion, it's about nearly 6 centimeters, not just a 3 centimeter mass. It was a big area as the breast was seen. It was 5.64, as you can see in the length. And this was craniocaudal or head to toe dimension of the mass, which was 3.4. That means with all these measurements are important, because we have to understand and plan how we're going to place the probe, where we're going to place the probe, and how, so that we cover not only the mass but also the normal 1 centimeter of tissue around it, because the margins should be clean too. So here the 4 o'clock mass, so 11 o'clock, 4 o'clock, 12 o'clock, 3 masses, and they're no longer just separate entities, because when you see her in person, it's a 9 centimeter by 9 centimeter. And going back here, So the 4 o'clock would be here, and the 11 o'clock here, and the 12 o'clock here. But the 11 o'clock was more than just that area. The whole area with all the redness and with everything, we knew this. If we had to really be successful, we should do the whole area, because it's one entity. And so here we had to plan the cryoablation zone. So we wanted to cover the 4 o'clock as 2, given the length of it. Now, one probe treats 2 centimeters of disease in a successful way. We have shown through trials that it is possible to successfully treat. Even the 5-year follow-up after ICE3 trial has shown excellent, pretty much 3.5% recurrence in 5 years, which is a very good number, I think, in general, even compared to lumpectomies. So we know 2 centimeter works. Now, to plan this out, we had to do multiple overlapping ablation zones, making sure to cover all the area of disease. And so it was like 7 ablation zones that this patient needed, and we were able to do. We use iSecure Medical. That's an Israel company that manufactures this device, and in that we place the liquid nitrogen in a tank. We have a probe which is here, which is inserted into the mass, and then we form the ice ball. So here you can see from this graph, this blue graph shows how fast the temperature drops when the liquid nitrogen freeze starts. It goes to minus 170 degrees Celsius within a minute. It's very rapid, and it can be stretched for the extent of time that is needed, and we usually prefer 6 minutes or more, so that it's definite killing of the tumor cells. So anywhere from 6 to 12 minutes is generally the understanding that we tend to do. We do a freeze, thaw, freeze. So in that process, we are able to freeze the tumor cells in and out, the water inside, the water outside, stop the blood flow for that period of time. So there's necrosis, there's no oxygen, there's no blood supply going to the tumor, and the tumor undergoes necrosis, and basically the cells are pretty much ripped open. If I can see the wall, the membrane is stretched when the water from outside comes in during the thaw phase, and the cell is no longer an entity to function itself. So in that way, there's necrosis and there's healing. Now this is an ice ball, which is shown here pretty dark, which is how it will be, and we stretch it to the extent that we make sure that it envelopes not only the tumor but also 1 centimeter around the tumor to cover the margin. Post cryo that day and the next few days, her breast was swollen, which is inevitable. She managed with a well-fitting bra, and for pain, Tylenol was all she needed. I'm not even sure if she took, but this is what we recommend. We like that inflammation so that the body is able to mount the response, immune response that is beneficial, and we want all the debris to go from there. So we want the blood to come, we want the lymphatics to work. So for the sake of the lymphatics, we would recommend a lymphatic massage therapist if needed, or some women have a vibration plate at home, like this patient had, that she was able to stand on for the whole body lymphatics. So something to remove the swelling and the edema, and monitor for fever, redness, discoloration, pain, increase in swelling, and contact your cryo doctor if any for this. So now we know before cryo she was like this on the day that she came to us. Now 1 month after cryo, she sent us this image where we can see skin blistering and areas of definitely the swelling had come down in a month, but the skin changes were noticeable. We knew that the tumor was touching the skin, and necrosis of the skin, back wall of the skin was going to happen anyway. How and a wound management doctor to take care of her, there were options that we would have provided. Patient were comfortable doing it at home herself because she had the large ulcerated lesion before that had improved. So in that process, she had learned how to manage, and these are some things that she did. She kept the skin dry. She applied topical silver sulfadiazine ointment about 2 times a day, and she also had a home ozone kit. It was basically 3 times a week for 10 minutes each, and basically this machine would form the ozone for her from oxygen, and then that was connected through a tubing through an apparatus that was placed on the breast. And she was diligent about it. 1.5 months or in 2 weeks time, she sent us a photo where we do see that the blisters have opened up and there is quite good improvement. Skin changes are still there, but it is going in the right direction. And a little bit later, we started seeing this change where near complete resolution of the skin changes with some scab still there. And I mean, she could have gone to a wound center and have this debrided by maybe a surgeon, but she continued to monitor and be at home and take care of it herself. And we did see it go down. It's shrinking and it's much better. The skin, she's the best part is she still has her own breast in spite of the journey she's had from the beginning. As you remember, it's a remarkable progression, and I think her motivation to stay confident and positive is playing a big role as well. So in the 3-month follow-up as ultrasound, she came to our facility. I was so amazed to see that the previously known that distinct mass was no longer there. It was all just bright echogenic changes with some edema. This is the area of the skin, central area where the skin had opened up, and there was no blood flow in that, and you can see the bright echogenic changes, and everything was just fat necrosis. Even the blood flow, you can see some color outside, that's all normal, movement related, and there's nothing in the area of cryo. So at 4 months most recent, the thing is still there, the skin scab, maybe she can have it removed, but that is nothing compared to the areas of malignancy that she had, that I think cryo has played in helping her in this journey. So just to show you a quick recap, so she had oncological treatment, holistic in 2022. As you can see, originally it was really significantly large, and then she had a little bit of a recurrence or a local recurrence in the breast, and then she had cryoablation and she is good. For now, she's being monitored. I continue to keep an eye, help her with the journey, and the native breast is in place. I think that's the benefit. Her own breast is there. I don't know, subjectively, I think that makes a huge difference. I'm not saying every woman needs to have only that. There's a role for surgery too. But if a woman is strongly motivated and that's important to her, then this option is available. No general anesthesia was there for this. She was comfort, only lidocaine. She had a very quick recovery, and in the big scheme of things, if she still needs surgery, that is still an option for her because her own breast is still there. So I'm really excited that we are in a day and age where this is possible. I mean, we have had cryoablation approved and used for 20 years for kidney tumors, for prostate, liver, even lung more recently. And I'm just surprised that it's taken such a long time for us to have it in the breast world. I mean, breast is so easy to access for procedures. So I'm just thinking that this is a great option, and I do wish more and more can benefit, and more providers can even come on board, because I think many women will benefit from this. I thank you once again for the opportunity, and I wish you and your family very good health always. Have a good day. Thank you.